This is Module 4, Use of Assistive and Adaptive Devices, in our continuing discussion of promoting successful rehabilitation outcomes in multiple sclerosis. Certainly we've seen that there are many challenges to mobility for individuals who are living with MS. And the physical impairments that we've already discussed in MS that impact mobility include weakness, spasticity, fatigue, the problem with balance dysfunction that we just discussed, as well as ataxia and sensory loss. There are many times when we have to consider the use of assistive or adaptive devices for mobility in MS. This can be a very difficult decision for the patient to be willing to accept the use of an assistive device, but when their independence and safety is at risk, we must do our best to really educate the patient about the value of using assistive and adaptive equipment. Canes, walkers, motorized scooters, and wheelchairs can all promote or maintain independence for the individual. They certainly will help to conserve energy since our major symptom is fatigue. They can prevent falls, reduce injuries, as well as add ease and pleasure to activities, which could contribute to an improved quality of life. But as I mentioned, there are barriers to use of devices. And the barriers are most often inappropriate device selection or improper fitting of the device. If a physical therapist is not involved in the prescription of the assistive device or in the orthotic for the individual, the patient often will not utilize the device because it is not promoting independence and safety. Failure to adapt devices to the patient's needs is another barrier to the patient utilizing the device. Unfortunately, financial and reimbursement issues can come into play, and the biggest barrier is the patient's attitude about now having to use a cane or moving from the cane to the walker. But the more time we spend in educating our patients about our goal to keep them independent in all of their mobility, and most importantly, independent and safe, we can convince the patients when it is appropriate to start to utilize adaptive devices. One of the newest devices on the market is certainly the functional electrical stimulation, or neuromuscular electric stimulation. We had technology before where we could utilize electrodes placed on the skin, and from the electrodes were wires that were attached to a portable device, which could cause stimulation of the muscles. Now we have wireless technology and even better electrode placement and compression that can afford the patient better opportunity to control their muscles. If we can stimulate muscle re-education, we can prevent or retard disuse atrophy, maintain or increase joint range of motion, and with the activity of the muscles, increase blood flow. These newer wireless technology provides more user-friendly electrical stimulation of the perineal nerve, but it can require complex calibration. A patient who is going to utilize a functional electric stimulation should be working directly with a physical therapist. It's also advantageous to introduce the patient to both the walk aid and the Bioness, as specific patients have difficult impairments which may render them more successful in using one device or the other. Let's watch a patient now walking with the use of a walk aid. As we watch this patient walk, she's ambulating with the use of a straight cane and no device applied yet for the lower extremity, no functional electric stimulation device. And you'll notice there's excessive amount of lateral trunk flexion to the left as she attempts to advance that right leg forward, hip hiking, circumducting, never dorsiflexing at the ankle. And there's even a challenge in advancing the left leg forward as well, plantar flexion and inversion, a very energy-consuming gait. Now she's ambulating with the application of the walk aid on the right lower extremity. Notice her overall posture. Her shoulders appear much more level. We don't see that excessive lateral trunk flexion to the left to assist in hip hiking, nor do we see as much hip hiking and circumduction in the right lower extremity. So the walk aid stimulating the perineal nerve is increasing dorsiflexion. Look at this view as the foot now is actually clearing the floor in dorsiflexion, and compare that to the left lower extremity where a device is not applied, still showing plantar flexion and inversion. As you can see by the patient's posture, she has more of a hemiplegic involvement with her multiple sclerosis with that right arm in a flexor spasticity pattern against her body. She's kind enough now to just lift her pant leg slightly to show the application of the walk aid on the lower extremity. Our next patient, also with multiple sclerosis, is demonstrating almost a kind of hopping step-to gait pattern. She has weakness and spasticity in both lower extremities, little less in the right, as she is able to advance that leg forward in some hip flexion, but drags the left leg. So the left leg was more involved. Therefore, we applied the bias to the left lower extremity. Look at the change in her gait pattern. No longer stepping and dragging that left leg forward, but actually demonstrating a step-through gait pattern. The device is applied on the left leg. We see more hip and knee flexion as well as dorsiflexion. There is not a device on the right leg, so you still see some plantar flexion inversion, just observe there. But look at now, she's even able to clear the little rubber edge of the carpet and ambulate. Mobility devices are very important for us to consider in order to keep our patient as independent and functional in the community as possible. We want to select devices that are portable, maneuverable, and can activate muscles when needed, but also enable the muscles to be at rest so that we don't contribute to more fatigue. In addition, we have to be concerned with integumentary hygiene, pulmonary hygiene, and energy conservation. There are a variety of mobility devices on the market, and we should be working with our patients to demonstrate which is the most successful to maintain their independence in the community. With this patient seated in the manual wheelchair, if you take into consideration that she needs to be able to move about in the community as well as her home, this particular mobility device is certainly not fitted to her accurately, nor does it give her the best opportunity for mobility and maintain energy conservation. First, you should note that the chair is really not large enough for her. It also puts her in a forward head and a rounded shoulder position. She's in a posterior pelvic tilt as she's sitting in the chair, and her hips are higher than they should be. So just sizing and modification of this chair should be changed for the patient for her comfort, as well as to prevent any further muscle contractures or deformities. In addition, it's a manual chair. She's going to have to use her arms an awful lot to propel the chair, and that will be difficult for her over a prolonged period of time, especially in the community. The chair does have swing-away leg rests, but they're not elevating. She is prone to developing edema in both lower extremities. She does have removable arm rests, but certainly a better device would be more appropriate for this patient. This gentleman is an EDSS of 8.5. The previous patient was an 8.0, so very similar in their levels of disability, but you can appreciate that this gentleman is in a chair that is much better suited for him for mobility in the home as well as community, and certainly even in posture and alignment. He's in a motorized wheelchair. It's a tilt-in-space chair. He has a joystick, removable arm rests, elevating swing-away leg rests. He's got a lumbosacral pad, which helps maintain lumbar lordosis. He also has thigh pads to prevent external rotation of the femurs. There's a headrest so that he can support his head if he gets fatigued throughout the course of the day. And in addition to the motorized wheelchair using the joystick, there is also a caregiver control which is mounted on the back of the chair so that the caregiver can mobilize the chair for the patient. We've discussed the use of the functional electric stimulation for our patients to assist in dorsiflexion of the foot to clear the foot through swing phase. And certainly the FES devices do assist in activation of the anterior tibialis. However, the patient may also need an orthotic device that gives more stability around the ankle joint itself, or actually assists in controlling the knee. When we need more stability about the ankle joint, or we need to control that genu recurvatum, we need to be looking at different types of ankle-foot orthotics. The picture on the left is the traditional ankle-foot orthosis, and this is a posterior leaf AFO. The picture on the right is a much lighter dynamic carbon AFO. And we do have to take consideration to the weight of the ankle-foot orthosis, as this can impact the patient's ability to complete swing phase. If the patient doesn't have difficulty with control of the knee or the ankle, then a device which simply assists in picking the foot up might be appropriate. These newer foot orthotics, the Dictus band and the Foot Up Orthotic, are bands that go around the ankle with a surgical tubing that's attached down to pins that are inserted into the eyelets of the sneaker or shoe. This band simply assists the anterior tibialis in pulling the foot up for swing phase. Again, the patient would have to have good control about the ankle, not require added stability of the ankle joint, and they would not be displaying genu recurvatum if they were going to be utilizing a dorsiflexion assist band. For the patient that has more difficulty with flexion of the hip, a device has been developed by physical therapists at the Cleveland Clinic Mellon Center that assists in hip flexion as well as knee and ankle dorsiflexion. The device is called the Hip Flexion Assist Orthotic, and as you can see by this picture, there's a pelvic band with larger tubing now that runs down to a strap that's attached to the top of the shoe, and as the patient weight shifts to the right and unweights the left lower extremity, the Hip Flexion Assist Orthosis helps with bending the hip, knee, and ankle to assist with swing phase. We see the Hip Flexion Assist Orthosis demonstrated with this patient with left lower extremity weakness and walking with a four-wheeled rollating walker. Notice how it's advancing the left leg forward by flexing the hip and knee so that the patient can clear their leg through swing phase. In this particular patient, she is also wearing an ankle-foot orthosis, so it can be used in combination with other orthotics. Now let's move our discussion to different types of devices. We've seen the four-wheeled rollating walker displayed before, and in fact, we saw Debbie use it. It's a very efficient way for her to have community mobility without challenge to her balance. The four-wheeled rollating walker obviously also has the seat for fatigue or problems with endurance, so that would be another consideration for a patient with multiple sclerosis. The two-wheeled rollating walker is also very stable for Debbie to utilize. Again, her primary problem is balance challenges, but it doesn't have the seat, nor does it have the basket to put other devices in or carry things around. So in Debbie's situation, she could use either the two-wheeled or four-wheeled rollating walker, but she certainly prefers the four-wheeler. It actually, with the four wheels, it actually gives her much more velocity to her gait. Different, obviously, now than the standard walker, which we're all so familiar with. You have to stop, place the walker step, stop, place the walker step. So for a patient who has greater instability, either from a weakness spasticity perspective or a very significant challenge to balance, you might want to use the standard walker. It will slow the gait up significantly. Also, with the standard walker, you have to lift the device up, so you have to have adequate trunk control and upper extremity strength versus pushing the walker forward as we're able to do with the two- and four-wheeled rollating walker. Now we're demonstrating Debbie, who, recall, has balance problems, walking with a straight cane. So the therapist is guarding during her gait here, and you see Debbie's gait change with the straight cane, a little bit wider base of support, some arm swing, but a little unsteady, certainly nowhere near the same gait velocity as she had with using the four-wheeled walker or the two-wheeled walker. A little hesitant misstep there as she was going through swing phase. So selecting the correct assistive device is very important for your patient. We're back to Dio, who we identified had some musculoskeletal changes, not only in the knees, but in those ankles and feet as well. Notice the significant pronation, and that tends to throw her center of gravity forward. So one of the things we suggested with Dio is that she try the Nordic walking poles. This actually helps to keep the trunk in a more upright posture versus unilaterally weight shifting and leaning on a straight cane. So it's not dramatic, but there is more of an upright posture to her trunk as she's walking. It helps to keep her center of gravity a little bit more posterior than anterior where it was previously using the straight cane. And for Dio, because she doesn't have significant neurologic deficits with her multiple sclerosis, for most community mobility, she simply uses the single walking stick. Again, it's enough to give her appropriate balance because of her altered center of gravity, which is, in her case, really more from the musculoskeletal changes in the hips, knees, and in the ankles. And here is Mike. We saw Mike walking previously using the straight cane and the dictus band, and that certainly enables him to be safe and independent in all of his community mobility. In fact, I should share with you that Mike plays at least 9 holes of golf 3 times a week in the summertime and uses his straight cane and dictus band. Another new pharmacologic agent that's available for our patients with multiple sclerosis is Ampera, or dalfampridine, and we referenced dalfampridine earlier in Module 1. Dalfampridine, or Ampera, has been used to assist in ambulation for our patients, and in fact the evidence is quite strong that it improves the gait velocity measured with the timed 25-foot walk. We're not quite sure how Ampera works, but the thought is we know with demyelinated axons we get leakage of potassium from the inside of the neuronal membrane out into the extracellular fluid. That loss of potassium inside the membrane then slows down, or actually stops, the propagation of the action potential down along the remainder of the axon. The thought in how Ampera works is that it selectively seals the potassium channels in the demyelinated axon, preventing the potassium from leaking out into the extracellular fluid. If there's more potassium inside the neuronal membrane where it belongs, that facilitates the propagation of the action potential along that demyelinated structure. As a result, we get better propagation of action potentials, resulting in a change in the patient's gait velocity. We have a case report to demonstrate the effects of Ampera. We had a patient that was diagnosed with secondary progressive MS, a 48-year-old female. She utilized a 4-wheeled rollating walker for her home as well as community mobility, but she had a complaint of certainly fatigue that we know was associated with MS, but also limited endurance with ambulation. When Ampera was available for use in multiple sclerosis, approved by the FDA, she started on Ampera and also started a new course of physical therapy, which included task-specific training, strengthening and functional postures, that core stabilization, stretching the spastic muscles, and then also redosing her intrathecal baclofen pump, which she had had implanted previously for management of spasticity. We had previous standardized measures of the gait performance for this individual back in July 17th of 2009. Timed 25-foot walk was 11.3 seconds. The timed up and go, 14.7 seconds. Timed up and go with distractor, which we'll talk about in Module 5, 19.5 seconds. The DGI out of a total of 24 was an 8, very high risk of falling. Her 2-minute walk, she was able to cover 168 feet. 6-minute walk, she covered 454 feet. And the self-report 12-item walking scale for MS was a 42. The middle column reflects her timed walk 1 year later, so July 29th, 2010. And this is after 8 weeks of being on Ampera and performing her physical therapy treatment twice a week. Notice the dramatic change in her timed 25-foot walk, now down to 8.9 seconds. And her 2-minute walk, she was now able to cover a greater distance, up to 207 feet from the 168 feet prior to the interventions. And in fact, 3 months later, her timed walk continued to be fast at 9.3 seconds. Her timed up and go was significantly different from prior to intervention, 11.7. Tug distractor was down significantly by 6 or 7 seconds, much improved. The DGI was improved up to a 14 now, total being a 24, which would be normal. 2-minute walk continued to improve up to 240 feet now covered in 2 minutes. And look at the difference in the 6-minute walk. 603 feet now covered in 6 minutes versus 454. And her 12-item walking scale self-report was at a 24, which is demonstrating her confidence and safety in ambulation. Module 5 will include a discussion of the special considerations in multiple sclerosis. And as we've already alluded to, these are going to include fatigue, heat sensitivity, challenges with cognition, bowel, bladder dysfunction, as well as pulmonary muscle weakness.